Each electrolyte do we need to know? And really what you just need to look at is what are the differences? How do I know that the signs and symptoms of hypocalcemia are different than the signs and symptoms of hypokalemia? So just look at the differences. That irritability and anxiety, for example, that's with everything. So would I really be concerned about that? Not necessarily. So some of the things like with hypocalcemia, the bleeding and bruising, the brittle hair, nails, the Chostek and Trousseau sign, those are significant and special for calcium. So just some of those kind of things. And then the other one was, which isotonic solution do we need to know? Really just normal saline. That's the one that I would concern myself with the most. I don't go into detail about that a lot on the test because, again, they change so much. So I just want you to know, though, that an isotonic solution is normal saline because that's what you're going to give the most with medicines and all kinds of stuff.
If somebody is receiving a hypertonic or hypotonic solution IV and they have to have a blood transfusion,
yes,
you stop that?
Stop it.
And then start it with normal saline?
Exactly.
Okay.
Yeah. It has to go with normal saline. There's no other. But that's a good question. Like if I've got a patient who's getting D5.5 with 20th potassium for some reason, and they need blood, you switch tubing. You will actually go through the process of even switching the tubing because there is fluid in that line. There's still fluid in that line. And it doesn't seem like it's a lot, but it is enough to make a difference. So, good question though. Yeah, you always will stop it and change it. So.
I didn't know if you would leave it running and then start the blood transfusion in another IV site.
No. I mean, you could potentially if they have another IV site, but that's rare.
What about like renal saline and potassium? Like I see them do that a lot. Just to decrease the burning, or is that something you have to do?
No. Most potassium when it's delivered IV is mixed with another fluid, some kind of normal saline or dextrose solution. It does prevent the burning, but it also dilutes that potassium further because you just don't want to give it straight. Now you will see some people get potassium as a secondary or as the piggyback, but it's a very small amount. And usually when they do that, they will run it at the same time with another solution. So, and remember, we never, never, never push it, right? Because that is a bad thing. I have that fear every time I teach this that somebody's going to do that one day, and they're going to say, well, Miss Ward never said that. Yes. So, make sure. Okay, housekeeping. Anybody have any housekeeping, anything? A couple of you have asked me about that sheet that Miss Walker gave you with the assignments on it. That IVCE article is what we did in class, so you don't have to worry about that anymore. I know it's still on there. I think the date was a little different, but just don't worry about that because we did it in class. Okay, just make sure that you click review on that page. Okay. All right, so we did hypocalcemia yesterday, right? So now we're going to do hypercalcemia. So what is the number for hypocalcemia? What's the 8.5. So 8.5 to 10.5 is what we consider normal for a calcium level. Hypercalcemia would be anything above 10.5 or 10.5 milligrams per deciliter. Okay. The main cause of hypercalcemia is hyperparathyroidism. And I've got that starred, 2 stars there, because that really is the main cause. That increased parathyroid hormone, an increased parathyroid hormone causes calcium to be released from the bone. Increased parathyroid hormone causes calcium to be released from the bone. So there's an increased absorption of calcium in the intestines and renal system. So that is the main cause. It's not a common thing. most of the time with a calcium imbalance, you're going to see hypocalcemia as opposed to hypercalcemia. But if you do have that situation, that's what it's from. Cancer, metastatic cancer, that CA over there is cancer, specifically metastatic.
What did you say there was an increased absorption of?
It adds to the absorption of calcium in the intestines and increased renal absorption. Now, something I want to add to that, anyway, is that if you have an increased amount of calcium, it can cause hardening of the bowel and the renal system. So if it's too high and it's absorbing more, it's free floating around and it's absorbing more, it can cause hardening in those areas. So you have to be really careful. Chronic hypercalcemia can cause a lot of issues.
Does it cause kidney stones?
It can, sure can. Calcium stones. Sure can. And you know, we are in the kidney stone belt. Anybody ever had kidney stones in here? Yeah. And calcium stones are the most common types of stones. And oxalate stones from tea. We drink a lot of sweet tea. All right, so back to this. Cancer, metastatic cancer, especially breast, ovarian, pulmonary, and multiple myeloma.
And what?
Especially metastatic cancer, especially breast, ovarian, pulmonary or lung cancer, and multiple myeloma, myeloma. The reason for that is those types of cancers will dissolve bone cells. And if they're dissolving the bone cells, it's like remember when we were talking about potassium and I talked about trauma and how when you have trauma, the cells burst and it releases the potassium. Remember when we talked about that? Okay. Same principle here is that as it's dissolving those bone cells, it's releasing calcium out of the system. Those types of cancers metastasize to bones. Okay, the reason I have President Kennedy up here, which you probably wondered, is because he had Addison's disease. I don't know if anybody knew that or not, but he had Addison's disease. And Addison's disease is rare, but those people who do have it frequently have problems with hypercalcemia. It's a failure. Addison's disease is a failure of the adrenal gland. To produce, failure of the adrenal gland, to produce cortisol and aldosterone.
Always scan this section.
Good.
Scan. Makes you turn what that is. I don't know why that is. I know that there is something like steroid hormones, cortisol, and aldosterone. You're going to be talking more about those types of diseases. She knows more about it. Yeah, you're right. They do change. Okay, so cancer, Addison's disease. If you Google images, you'll see people with Addison's disease that have an orange tint to their skin. It has something to do with steroid hormones. And then people with HIV or AIDS have trouble with hypercalcemia as well. And it's the way that that disease process destroys the cells in the body. Okay, so those are the most common. Again, the most common is that hyperparathyroidism. All right. Okay. Now, we can have too much calcium. We can have an excessive intake of calcium. So we have too much calcium, vitamin A, and vitamin D. What's the relationship between calcium and vitamin D? It helps with the absorption, right? Okay. So if you're taking too much vitamin D, what would that do to the calcium? You're absorbing more calcium, right? You're absorbing more calcium. So that's the problem with that. Paget's disease. Have you ever heard of Paget's disease? Paget's disease is a chronic disorder that's characterized by the breakdown of bone tissue. Characterized by the breakdown of bone tissue. And what happens is that as they develop, or as they're growing, trying to grow and develop, their bones become misshapen because the bones are chronically broken down. And again, if they're broken down, then what's that doing with the release of the calcium? Increasing the release of the calcium, isn't it? There is no known cure for Paget's disease. We probably don't talk much about that else in the curriculum, so I just want to kind of just let you know what it was, because it's not a common thing. It's pretty rare. Okay. Prolonged immobilization, because what does prolonged immobilization do? Break down bones, doesn't it? Breaks down the bones and there's not that regrowth or reformation. Sarcoidosis. Have you ever heard of sarcoidosis? Sarcoidosis is a multi-system disorder. Causes the vessels of the body to harden. 90% of people with sarcoidosis, the system that's the most affected is the lungs. And that's the saddest part about sarcoidosis. There's no cure for sarcoidosis, is that eventually they suffocate because their lungs harden to the point that they're rock hard. They can't expand or, to relieve, to breathe, do the in and out. Inspiration, expiration, they can't do that because it causes all those vessels to harden. Okay, milk alkali syndrome. Have you ever heard of milk alkali syndrome? It's the excessive ingestion of calcium. It occurs with too much ingestion of Tums. People who take, anybody that takes Tums chronically? I actually am kind of bad about that. Okay. Too much ingestion of Tums or milk. Or anything that has sodium bicarbonate in it. And then anybody who's on lithium or any of the Thiazide Diuretics cause retention of calcium instead of excretion of calcium.
How much milk would you consider too much? Is it like a whole lot more than a person normally?
Oh, yeah. Constant, chronically drinking milk.
Kids drink a lot of milk.
Right. This is like all the time. Yeah. Okay. You'd have to take it a lot. These are the people who eat Tums like it's candy, especially, just all the time. Okay? All right, so what do these people look like? Neuromuscularly, they have depressed deep tendon reflexes or decreased deep tendon reflexes. Impairment of memory and bizarre behavior. Now, a lot of these electrolyte imbalances, though, cause confusion and lethargy, don't they? Yeah. So again, when I'm studying the symptoms of the electrolytes, I would be studying things that would really tell me that this is a specific type of electrolyte. Headache, fatigue, hypertension, cardiovascular, they have hypertension. They may have some dysrhythmias, so if you're listening to their heart rhythm, it would be abnormal. Renal, we mentioned about the causes. They have a tendency to develop renal stones and renal colic. What is renal colic? Anybody know? It's a spasm-like pain in the kidneys. GI, they have hypotonic bowel sounds and constipation. Yeah, sorry, hypoactive. Hypotonic and hypertonic.
Like, you're pretty good if you can hear that.
Huh?
You're pretty good if you can hear if it's hypotonic.
I know. I'm talented. Okay, musculoskeletal. Now this is a little different than hypocalcemia. Remember we talked about how the bones just start to break down. They become spongy and porous like osteoporosis, right? With hypercalcemia, the bones thin. So it's kind of like, you know how when you shave off something, you're like shaved, so they become thin instead of spongy. So you still have a risk of fractures, but it's a different type of fracture. So if you looked at this bone on X-ray, it would look like it's been shaved off. It's wearing down. It's thinning.
How about like bone spurs or anything like that?
It could cause bone spurs.
Is that the same as brittle?
Similar to brittle bones, yeah. They complain as well of bone pain. You know, the hypocalcemia complains of bone pain as well. These complain of bone pain too. It's different because it's thinning bones. But they have a high risk of fractures as well. It's like walking on little toothpicks after a while, you know, because their bones are so thin. Okay. So it's a little different than your other one, just making sure everybody understands that. Okay, so nursing diagnosis is pretty much similar to what we've had before. Decreased cardiac output, that's what CO stands for, cardiac output. Constipation, injury, nutrition, knowledge deficit. All those are on those slides. All right, so let's talk about what we do for these people. Interventions. Okay, dietary. Okay, we have to decrease. How much calcium did we say we needed for? 1,000 to 1,500 milligrams a day for hypocalcemia. In this case, we need to decrease the amount of calcium that we intake. So less than 400 is recommended a day. Now, you have to have some, right? We have to have some calcium. We can't totally take it away. Otherwise, our bones would totally fall apart. But we limit the amount. And we increase the amount of fluids that we take. Because what is that going to help do? Wash it out of the system, right? And remember, we're at risk for developing calcium stones in the kidneys. So the more water you drink, the better off it's going to be, right? You're flushing out the renal system. So anywhere from 2,000 to 3,000 milliliters a day of water. Mountain Dew does not count. Just water. 2,000 to 3,000. Mm-hmm, 2 to 3 liters. Now, they also recommend increasing liquids that are considered acid ash. Those are the like prune juice and cranberry juice that are very acidic. When they're called acid ash because they're the berries that have the skin on them. You know, prunes and cranberries have that. But they also increase the acidity of the urine. What might we want to increase to prevent constipation? Fiber. Right, fiber. Because they're at risk for constipation. Now again, this would be mild hypercalcemia. You cannot correct a severe hypercalcemic state with just diet. Or it would be something that you would send them home, educating them on this kind of stuff. So if they're in the hospital, there are other things that you can do. Orally, medication-wise, loop diuretics will cause calcium to be excreted. What type of diuretic causes it to stay in the system? We just said it. Thiazide diuretics prevent it from being excreted. So people who are on HCTZ, and you're going to see a lot of people on HCTZ at the hospital for blood pressure control, hydrochlorothiazide, that has that diuretic in it as well, they are at risk for hypercalcemia. They have to be really closely monitored for that. But back to this, loop diuretics cause calcium to be excreted. Corticosteroids inhibit calcium to be absorbed in the intestine. Corticosteroids. So that would be like your prednisones, your solumedrols. It inhibits calcium to be absorbed in the intestine. Now, corticosteroids were one of the causes of hypocalcemia. Okay, so if you've got somebody who has low calcium levels, steroids are one of the causes. So back to that, what kind of patient would be on steroids all the time? Okay, any of the failures? Rheumatoid patients, arthritic patients? What about our respiratory patients? Yeah, COPD, emphysema, asthma. So those people have to be really careful because that chronic use of steroids will cause them to be hypocalcemic. Okay. If it's severe enough, they can give isotonic IV fluids. So that would be our normal saline. Isotonic saline will dilute calcium, but you have to give it in large amounts. So when I'm saying that they give normal saline, you would be giving them a big bolus of fluid. I mean, a huge amount of fluid. But again, it's just like drinking your 2 to 3 liters a day. The more you drink, the more it's going to excrete, right? So to get rid of it. There is a drug called mithracin, M-I-T-H-R-A-C-I-N, mithracin. It is a calcium chelating agent, C-H-E-L-A-T-I-N-G, C-H-E-L-A-T-I-N-G, chelating agent. And what it does is it will bind, and remember how we talked about K-Exolate and how it binds the potassium, exchanges it for sodium and excretes it in the resin. This is the same kind of principle. It binds the calcium to this drug, and it's excreted through the GI tract. So it's the same principle. Causes it to stick to it and then get it out of the system. So if you've got a severe case, that would be a...
Wouldn't it need to replace it with something?
Not with calcium. Not with calcium. Yes, babe.
How is that given?
Orally. It isn't oral. As opposed to your K-Exolite, which can be given oral or enema, but it's mostly enema. Okay, so when we're educating them, of course, we're saying, as we're doing these treatments, we're monitoring for signs and symptoms of hypocalcemia as well, aren't we? Because remember, we don't want to overcorrect. It was like our fluid volume deficit. You can't overcorrect and go the opposite way. So you never, so you're teaching them signs and symptoms of tetany and seizure activity and bleeding and bruising, those kind of things, as well as signs and symptoms of hypercalcemia. Okay, pull out your calcium cake. So what does sodium do? So what Jeff was saying is about skeletal muscle contraction. It helps to maintain blood volume and blood pressure. We know that. It is essential for nerve impulse transmission. And it's also, one thing he didn't mention is that it's essential for the sodium-potassium pump, right? Which keeps sodium outside the cells and potassium inside the cells, right? So it's very important in that aspect. Okay, so everybody remember that sodium-potassium pump stuff? Okay. All right, so hyponatremia is the most common electrolyte imbalance in the United States. Of all the electrolytes, this one is the most common. And it's one of the reasons is because that it's associated with what? Fluid imbalance, isn't it? It's associated with fluid imbalances. So, hyponatremia is anything below 136 for our testing purposes. Anything below 136. The problem with hyponatremia is that the signs and symptoms that we're going to talk about in a minute are not usually apparent until levels drop below 120. So it has to be fairly low for you to start exhibiting the signs and symptoms. Okay? 120 is when we really start to see signs and symptoms. Okay, now, an actual deficit. We're going to talk about actual deficits and relative deficits. Remember we talked about that with which one? Remember? With potassium, remember? So we're going to talk about that again. An actual deficit is when an individual has a condition that's directly related to the sodium deficit. So, for example, GI, the vomiting, the diarrhea, enemas, GI surgeries. All of those, vomiting, diarrhea, enemas, suction. Wouldn't NG suction be a problem? Anything where GI fluids are lost. The integumentary system, we lose sodium through sweating, through diaphoresis. Through burns. This is still actual. Mm-hmm. So diaphoresis, burns, wound drainage. So when you think about the skin, anything that's losing fluid or moisture from the skin, burns, wounds, sweating. The renal system, people who have excessive diuresis. So your diabetics, right, the polyuria, or diabetes insipidus. We talked about diabetes insipidus, where they urinate lots and lots and lots. Those patients would have trouble with sodium. When we look at the endocrine system, decreased aldosterone secretion. Aldosterone secretion.
Increased?
Decreased. Every time I hear something drop, I jump, because several years ago when I first started teaching, it was probably 8 or 9 years ago. I had a patient, it was quiet, everybody was listening to what I was saying, and everything was hunky-dory, and I heard a crash like that, and somebody had passed out in the middle of the row and fallen in the floor. In class. It was, yeah. And the people who were sitting beside her were like, so every time I hear something like that, I'm like, oh, somebody's passed out again in the class. I know this is boring stuff, but okay, medications. There are some medications that will cause sodium to be lost. Diuretics, and before we leave today, we're going to do a real quick review of our diuretics, just to make sure we know which ones lose what and all that stuff. ACE inhibitors will cause hyponatremia. And of course, inadequate intake. So if you've got somebody who's on a low sodium diet, maybe you've got somebody who has high blood pressure and they're just really, really good at, typically you don't really have this, because most people who say, the physician says, don't eat salt, you know, they do still anyway. Miss Walker's real bad about that. But anyway, people who don't salt their food can have an inadequate intake of sodium. Okay, and then we've got the relative deficit. Relative deficit, remember, it's related, but it's not an actual cause. Relative deficits may be caused by like water gain or third spacing. So like excessive intake of your hypotonic fluids. Excessive intake of hypotonic fluids. Not enough solute in them. Pulls it out. Adrenal failure. Hyperglycemia. Hyperglycemia causes water to be pulled out of the cells. So when you've got a diabetic, not only are they urinating so much, but they're also, the glucose causes water to be pulled out of the cells. They become very dehydrated. The cells become dehydrated. And then it causes the water to be in the extracellular fluid, so it dilutes that extracellular fluid. So it's diluting the sodium in that extracellular fluid. Does that make sense? SIADH, which is syndrome of insufficient ADH production. It also can dilute the sodium that's in the extracellular fluid because it causes retention of fluid. What about people who have things like congestive heart failure? You think they can be diluted too? Yeah.
What did you say, SIADH?
Syndrome of insufficient ADH production. And then again, third spacing, where you have edema, fluid building up in the tissues, dilutes the sodium that's in that extracellular space. Excuse me. All right. Assessment. Now, with sodium, your biggest symptom that you really need to pay attention to is neurological. Remember, it is essential for us to have sodium for nerve impulse transmission, right? If we don't have enough, then we can have neurological symptoms. And one of the biggest ones, and when I put my notes up for you today, because I'm going to put my notes up for you all today under the PowerPoints, it will say seizures in big bold letters, because that is the biggest thing you're looking for with these patients is seizure precautions. Okay. They also will complain of a headache, lethargy. Remember, lethargy and irritability, everybody has that with all these, right? Hallucinations. But seizures is the biggest one for this one. Neuromuscularly, they complain of muscle weakness, decreased deep tendon reflexes, muscle spasms, and twitching. GI, they will complain of abdominal cramping, nausea. They have frequent watery diarrhea, which is a problem because they're losing more sodium, aren't they? So not only can the GI symptoms be a cause, but they can also be a symptom as well. Do you see how that works? You can have it both ways, cause or a symptom. Now, if you do have any cardiac changes, it occurs more frequently in patients who have hyponatremia with hypovolemia. Because remember, sodium follows water, water follows sodium, you know. So if you have a fluid volume deficit, that's when you're going to really start seeing the cardiac sides of the hyponatremia. And that's your rapid, weak, thready pulse. If you've got a hyponatremia that's due to something else, you're not going to see that rapid, weak, thready pulse as much. So that's really with especially like your hypovolemic shock patients. Holly was just saying that the other day when we were talking about hypovolemic shock, that she went home and a neighbor of hers has a cousin, or
Our nanny.
your nanny has a cousin who is not looking too swift with hypovolemic shock.
Yeah, he thought he had the flu. And by the time we got to the ER, he had a temperature of 106. And so his blood pressure's been super low, and they're not going to make it. It was like 46 over 16 last night. Wow. So
And he's 31.
Wow. Yeah. Brand new wife, no kids.
Yeah. Yeah. Not expecting him to survive. So it's serious business. That's why I wanted to really kind of introduce you to that hypovolemic shock situation, because it's nothing to play around with. Definitely. You know, we're up to 21 or 22 deaths right now from the flu in North Carolina. And, you know, a lot of them have been younger people. So, got to be careful. Everybody be careful. Okay, renal, you'll see urinary retention. And then respiratory-wise, bradypnea, so slow rate, and hypoventilation. Slow respiratory depth and a rate. Hypoventilation and bradypnea. Okay, so how do we fix these people? Intake-wise, remember if it's mild, again, it goes along with the same thing that we did before. If the deficit is mild, if they can swallow, and if what? What's the third one? Thirst is intact. Okay? So we're increasing their oral sodium intake. You have to, with these patients, though, restrict free water. Why?
They're not getting this.
Because they're going to urinate it out, aren't they? Okay. There is, if you look at your chart, your IV chart, there is hypertonic saline, which is an excessive amount of saline, like 2 to 3% saline, IV saline, instead of our normal 0.9%. 2 to 3% is a pretty big amount of sodium. But you can give hypertonic saline if it's a severe situation. If volume is an issue, so if you've got a patient who has hyponatremia with hypovolemia, then they're going to try to do, they'll just do normal saline along with some other things so that they can get the, you don't use hypertonic saline to correct a volume issue because there's too much sodium in it. Okay, other medications, you're treating symptoms. So if they've got a headache, analgesics. If they're vomiting, an antiemetic. If they're starting to show signs of seizure activity, the drug of choice for this one is Dilantin. There's some medications that affect electrolyte imbalances. Remember, we talked about some of those already. So for this one, Dilantin is the drug of choice for any seizure activity. Dilantin, Dilantin. I should say Dilantin. That's my southernness. Dilantin. Steroids to decrease any edema. And of course, when you're educating this patient, you're educating them on how did they lose the sodium to begin with. Was it strenuous exercise? Were they out in the hot weather and they were perspiring too much? Did they just not intake enough sodium? Sodium, though, is very important. And again, the signs and symptoms don't occur till it's really low, but it is the most common electrolyte imbalance around. So I'll be real careful about that. Okay, hypernatremia. Hypernatremia is a serum level above 145. What was our low again?
136.
135, 136 to 145. Okay, again, why do we gain sodium? Excessive intake. Do you remember we talked about our near drowning? Near drowning in salt water will cause a hypernatremic state. Not the lake with the mud, just the salt water. So the ocean. Okay. IV solutions and formulas that are not properly diluted. What does this sound like? Fluid volume excess, doesn't it? Overuse of hypertonic saline. And then all those things, the retention is all those things that we talked about just a minute ago for the opposite of what we talked about a minute ago for hyponatremia. They have produced too much aldosterone. And remember, just kind of a flashback to anatomy, the adrenal gland and aldosterone regulate water retention and sodium retention. So too much can cause too much water and sodium retention. What about renal failure? Do you think if they're not outputting, they could start building up? Yeah.
Mm-hmm.
Okay. Excessive water loss without sodium loss. And then just inadequate water intake. I mean, you just don't drink enough. And again, it goes back to some of your age groups too. Some people are just unable to ingest amount of fluids. You know, Jeff was asking when we were talking about fluid volume deficit, we were talking about thickened liquids. And you can get, do you think about this too? Do you think thickened liquids could be on the same type of level as inadequately prepared formula?
Yeah.
Yeah, you can thicken liquids too much. Yeah. And then you can have too much solute as well. So you got to be really, really careful about that. So we mentioned formulas and TPN and stuff like that before, but you really do probably need to add your thickened liquids to it as well. You've got to be real careful about that. Okay, usually with hypernatremia, the first symptom to appear is thirst. But remember, just like with hyponatremia, it's going to have to be, you know, significantly higher, probably 150, 155, for the symptoms to start to appear. And it's like eating your Mexican food. Remember we talked about that the other week? So we eat too much. I could eat it every day, but boy, it makes you thirsty. It's just too much salt. Cerebral symptoms, agitation, seizures, confusion. Now, I want to remind you about something too. Remember we talked about how cerebral cells or brain cells are really sensitive to water changes? Remember that? So in the presence of hyponatremia, those brain cells will swell. In the presence of hypernatremia, those brain cells will shrink. And if it's severe enough, that is one of the reasons that the seizures may occur. Okay? Because remember, the water follows sodium. So in the presence of hyponatremia, they swell. In the presence of hypernatremia, they shrink, they shrivel up.
So you have seizures in
You can. And it's because of either or. If you've got too much edema, brain swelling, it will cause seizure activity. And if the brain cells shrink, you can also have seizure activity. But seizure activity is the biggest concern with sodium imbalance. You know, your bone pain and brittle bones and stuff with your calcium and all that stuff. Potassium is cardiac. Sodium would be seizure activity. That's your nerve impulse control. Okay, muscle twitching. If the sodium level becomes too high, gets really, really, really high, it can lead to paralysis. Okay. Yes, baby. No, not necessarily. It can be corrected. Cardiac, they'll be tachycardic. Renal, they'll have small amounts of dark yellow urine. It'll be very concentrated. And then respiratory-wise, it's severely decreased. Same with hyponatremia. The respiratory system is still affected to the point where if it's not corrected quickly enough, they can go into respiratory arrest. So they would have to be on a ventilator. Okay. All right, intake of sodium. So in this case, we're going to decrease the amount of sodium. Where is sodium found? And I think I put a little chart up for you. Did y'all see the sodium restricted foods? Did y'all get that? It's just kind of a little, because I think that's one of the most frequent diet restrictions that you're going to see at the hospital. So that's why I wanted to make sure that you knew this. So foods that are high in sodium, most of these you probably already know. I don't know about processed cheese. Did you know that? There's a lot of sodium in it.
All the good stuff.
All the good stuff, right. All the good stuff is on the high sodium side. Canned, processed, or pickled. That's what they always say. Canned, processed, or pickled. Canned soup is really high in sodium, too. That's why they're starting to make the low sodium versions. Canned vegetables. Yeah, all the good stuff's on the left side. And then all the boring stuff's on the low side. Food's lower than, so anything fresh. So that's really a rule of thumb. Canned, processed, or pickled is high in sodium. Fresh foods are low in sodium. But they taste nasty. Right. Sodium-free spices, flavorings, soups made with fresh veg. But remember, again, what do we have to be careful about with same with our fluid volume excess and our potassium patients. What do we have to be careful of with this? Salt substitutes. And we mentioned salt substitutes with potassium, didn't we? Because they're high in potassium. So you still have to be very careful with that. And a lot of people who are on low sodium diets, that's what they want to do is add Mrs. Dash or whatever some of those other ones are. It really can create some problems. So ensure a lot of water intake and adequate water intake. If they need fluids, they will make sure that they are hypotonic salines. Hypotonic, so you're like 0.25 normal saline, your quarter normal salines. Loop and thiazide diuretics promote sodium loss. So that's a good option.
Did you say they need an adequate or inadequate water intake?
Adequate water intake. You're restricting it with hyponatremia. Okay, so avoid high sodium foods. We talked about that. And medications that contain sodium. Alka-Seltzer is an example. A lot of people don't realize contains sodium.
Nasty.
Yeah, it is nasty stuff. There's a lot of those tablet type medications contain a lot of sodium. What are seizure precautions? Padded side rails and headboard.
Turn on the side.
Yep, turn them on their side if they need it. What else do you have at the bedside just in case to ward off evil?
Crash cart.
Well, the crash cart, but to ward off, if you ever have a patient who's being admitted for seizures or has a potential of seizures, like in this situation, you make sure the side rails and the headboard's padded. You put oxygen and suction at the bedside and test it. I cannot tell you how many seizures we've been in up on peds where we get in there and the suction and oxygen are not, they won't work, they won't turn on. So whenever you're admitting somebody, go ahead and take the oxygen tubing out of the package. It's okay. Plug it up. Make sure it works. Take a suction, like a yonker. Take it out of the package, hook it up to the suction, turn the suction on, make sure it sucks. Because if you're in the middle of a seizure, you don't want to be, running around trying to find your equipment. So oxygen, suction, and padded side rails. Very, very, very important. Do you stick anything in their mouth? No.
They used to say,
You used to put something in their mouth, like a spoon or something, a piece of wood or whatever. No. And then all these poor people had broken teeth, and so you don't do that anymore. Okay, one final think, pair, share. Find a friend. Thiazide. Thiazide is another one. So any of the Zides. Loop diuretics is the most common thing you're going to see, the most common type of diuretic you're going to see. You lose everything with a loop diuretic. Sodium, potassium, calcium, and magnesium. An example is Lasix. It's a loop diuretic. Most common one. Osmotic diuretics, loss of sodium chloride and potassium. An example is mannitol. You really don't see osmotic diuretics given often. You'll see them in an ICU or critical care setting. That's when you see them most. And then the carbonic anhydrase, you very rarely see that either. Loss of sodium, potassium, and bicarbonate. The reason you don't see that very often is because the more that those are given, the more acidic a person can get. So, because you're losing all that bicarb. So the person can very easily go from one situation to a metabolic acidosis situation. So you really have to be careful with that. And Diamox is one, and again, that's one that you see more often in chronically or critically ill patients. So your thiazide and your loops are the ones that you're going to see the most. And the biggest thing to remember about thiazide diuretics is the calcium reabsorption. Might that be something you would want to give in a hypocalcemic situation, though? Yeah, you could, because it promotes calcium reabsorption. So you could. Okay, but just again, you have to be careful. All right, what I want you to do last but not least is you should have at least 3 sticky notes in front of you, right? Okay. I want you to get with your